All right, let's get started. Good afternoon, everybody. My name is Michael Yudell. I chair the Department of Community Health and Prevention at the Dornsife School of Public Health at Drexel University. Welcome to another in our dating back months now series of webinars about the COVID pandemic. Today, we're going to be talking about what happens when we have a vaccine. And we have three incredible guests who will be speaking to different aspects of vaccine rollout, and we'll get to them in just a moment. My job here today is to provide just a moment of context at the outset of our time together today. Then I will introduce our speakers. We will hear from them about 10 minutes each. We'll have a short discussion between ourselves, and then we will open it up to Q&A from the almost 100 participants who have joined us here today, which is fantastic. So thank you for taking time out of your busy days to be here with us this afternoon. So here we are. It's late October 2020. We are still mostly indoors in these COVID times. Back in March, when we were told we would have to endure this for just maybe a couple of weeks or maybe a month, I don't think anybody expected, except the epidemiologists among us, what was to come in the coming months. We have seen a mixed bag in the public health world in terms of response to COVID. We know that masking is a great strategy to prevent the spread of COVID, and we've seen the politicization of mask use. People have been trying to social distance, but we have mostly been waiting for a biological intervention to stop this pandemic, that being a vaccine. And there are a record number of trials underway in this short period of time that the country and the world waits results on. There are now more than a handful of phase 3 clinical trials that are going on around the country, and we are hoping and expecting that we will start seeing approvals from some of those in just a few short months, if not into the new year. Challenge, of course, will be what happens when we have a vaccine. Who gets it first? How is it distributed? And how are we distributing it in a way that is equitable to the populations who most need it? And that is especially important in these difficult political times where everything, it seems, is being politicized. Now, of course, vaccines date back a few centuries. Edward Jenner invented the first vaccine against smallpox at the end of the 18th century. And we saw almost 2 centuries later, that pathogen eliminated from natural transmission by around 1980. So we can and do control dangerous pathogens through vaccination. But just as COVID and the potential COVID vaccine have been politicized, so too was the smallpox vaccine, and have many others. So it is really important for us to think about ways to distribute vaccines in a way that engender public trust, and in a way that keeps the public safe. Today's distinguished panelists, 2 of whom are members of the National Academies Committee on Equitable Allocation of Vaccine for the Novel Coronavirus, are going to share their expertise on that National Academies panel on the challenge of health communication and vaccine hesitancy during this difficult time, and finally on challenges to vaccine distribution here in Philadelphia. I expect our discussion today will focus on some of the epidemiological implications of vaccine distribution, on some of the ethical and health communication implications of vaccine distribution, and of course, on some of the policy implications of vaccine distribution. So it gives me great pleasure to introduce our 3 incredible speakers today. First, Diaz-Roux, who is Dean and Distinguished Professor of Epidemiology at the Dornsife School of Public Health here at Drexel University. She originally trained as a pediatrician in her native Buenos Aires, and completed public health training at the Johns Hopkins University School of Hygiene and Public Health, just south of us in Baltimore. Before joining Drexel, she served on the faculties of Columbia, the University of Michigan, where she was chair of the Department of Epi and director of the Center for Social Epi and Population Health. Dr. Diaz-Roux is internationally known for her research on the social determinants of population health and the study of how neighborhoods affect health. Her work on neighborhood health effects has been highly influential in the policy debate on population health and its determinants. Welcome, Anna. Thank you for being here today. Second, I'd like to introduce Alison Buttenheim, who is the Silverstein Endowed Term Chair in Global Women's Health and Associate Professor of Nursing and Health Policy at Penn Nursing. Dr. Buttenheim is a public health researcher and behavioral epidemiologist who combines her interest in behavioral economics with a focus on improving child health on a global level. She has designed and evaluated interventions to improve parental and family decision-making across a broad range of topics, including food access in low-income neighborhoods, childhood obesity, vaccine hesitancy, and participation in large-scale vector control programs. Welcome, Alison. And finally, Caroline Johnston, who is Acting Deputy Health Commissioner and Director, Division of Disease Control at the Philadelphia Department of Public Health. Dr. Johnson is serving in the role of Acting Deputy Health Commissioner following appointment in July 2015. Previously, she had been the Director of the Division of Disease Control for the Philadelphia Department of Public Health for 11 years. Dr. Johnson manages departmental divisions addressing maternal and child health, chronic disease prevention, childhood lead poisoning prevention, disease surveillance and control, environmental health services, air quality, the public health laboratory, and the medical examiner's office. Before joining the Department of Public Health, Dr. Johnson worked as an infectious disease physician and researcher at the Medical College of Pennsylvania and the Philadelphia VA Medical Center. Dr. Johnson is a graduate of the University of Maryland Medical School and did postgraduate training in Boston and Los Angeles. She's board certified in internal medicine and infectious disease, and her areas of special interest include child and adolescent health, epidemiology, and health risk communication. Welcome, Dr. Johnson. Thank you all for being here. It's great to see you, and I'm going to turn to my dean and my boss, Dr. Diaz-Roux, to start us off today. Thank you, Anna.
Okay, thank you very much, Mike. So I'm going to start us off by sharing with you some of the key findings of and recommendations of the committee that Mike mentioned that Alison and I both served on. So I gather you can see my slides, right? Yes, okay. So this report was launched a couple of weeks ago, and it's an important report because it's very relevant to the topic that we're going to talk about today. And it was the National Academies of Medicine does report studies in response to requests from various groups. It's an independent organization. And in this case, the CDC and the NIH charged the National Academies of Sciences and the National Academy of Medicine with doing a study and providing a set of recommendations on vaccine allocation. This is a very diverse committee with people from very diverse backgrounds and with expertise that worked at a breakneck speed, as Alison knows, over August and September to get this report out. So the committee was charged with developing an overarching framework for vaccine allocation to assist policymakers in both the domestic and also with some global health implications in planning for equitable allocation of the vaccine. And the idea is that this framework would be adopted and adapted by various agencies and local public health agencies to deploy the vaccine once it becomes available. The committee worked in various ways, multiple meetings, surveying, the information available, but also getting input from the public. So I just wanted to highlight that the committee did get input through various public meetings and incorporated much of the input into the final set of recommendations. So a couple of things on sort of the framing and the background that the group really considered. A very important element in the conversations and the deliberations and the recommendations that the committee put together have to do with, the impact of COVID-19 that we've been seeing, and certainly its disproportionate effects on racial and ethnic minority groups, linked to social and structural factors, and also factors like age and other pre-existing conditions that place some individuals and communities at higher risk. And so you'll see that the theme of equity in the allocation and sort of how the vaccine allocation interfaces with health equity considerations was a very prominent in the committee's discussions. Another thing, and I'm sure we'll talk more about this, but that there's a lot that we really don't know yet about what kind of vaccine we're going to have, including when, not only when, but also how many doses and how many time, the timing of those doses, whether it's going to work the same in all groups, et cetera, et cetera. And so we have to keep this in mind as we think about planning for the future, that we will have to be flexible and adaptable as we know more about what kind of vaccine or vaccines, because there could be multiple vaccines we have. So the first thing the committee did is develop a framework, and I think it was very important to start off. We spent quite a bit of time on this, is sort of defining some principles that should guide the allocation. And this may be obvious to some of you, but I think it's still important to make this very explicit. And the committee identified three key ethical principles. One is maximum benefit, so the obligation to protect and promote the public's health, as well as the socioeconomic well-being of the population in the short and long term. Equal concern, which means that every person needs to be considered and treated as having equal dignity, worth, and value. And last but not least, this ethical principle of the need to mitigate health inequities, the obligation to explicitly address the higher burden of COVID-19 experienced by certain population groups. And in addition to these three ethical principles, the committee also identified three principles that have to do more with the process through which the vaccine is allocated. And that includes fairness, impartial decision-making, and even-handed application of the allocation criteria, and also engaging with various community groups and with those most affected. And I'm sure we'll come back to that today. Transparency about what we're doing and why we're doing it, and basing our recommendations on the evidence that we have. So using these principles, the committee identified an overarching goal of the allocation framework, which balances reducing severe morbidity and mortality, as well as the negative societal impact due to the transmission of the virus. And so it's reducing the health impact, but also other societal impacts of the virus. And you'll see how this plays out in a minute. So using the ethical and procedural principles and this overarching goal, the committee came up with phases for the allocation. And in determining the different population groups that would fall into these phases, the committee balanced a number of considerations, including each population group's risk of acquiring the infection, of becoming infected, of having severe disease or even dying of the infection, the negative societal impact that group could suffer if as a consequence of the virus, and also the risk of transmitting infection to others. So this was quite challenging. We had a lot of conversations. And finally, the committee came up with four suggested phases. A first phase, which includes a jumpstart phase, where the focus is on high-risk healthcare workers and first responders. Secondarily, people of all ages with comorbid and underlying conditions that put them at significantly higher risk, as well as older adults living in congregate or overcrowded settings. A second phase, which expands to a broader set of groups, including K through 12 teachers and school staff and childcare workers, critical workers in high-risk settings, including people like essential to the functioning of society, public transportation workers, food processing workers, people of all ages with comorbid and underlying conditions that put them at moderately high risk, people in other congregate settings, including homeless shelters, prisons, jails, and staff who work in these facilities, and all older adults not included in the first phase. In the third phase, young adults, children, and workers in industries and occupations important to the functioning of society, and at increased risk of exposure, but who are not included in phases 1 or 2, and then the rest of the population. So you might start to see here how there's a sort of a transition initially from protecting those at highest risk of severe disease and death to focusing on groups where transmission and transmission to others is more likely to occur. And one cross-cutting theme shown at the bottom of the slide is equity. And so you'll notice that some of the groups at highest, who suffer highest risk of COVID-19, some of the differences are, in some of those groups are captured through the phases, because we know, for example, that the higher risk of COVID-19 in Latino and Black people often has to do with the kinds of jobs that people have. And so some of this is captured through some of these phases. But in addition, the committee highlighted equity as a cross-cutting consideration and suggested that that in each population group, vaccine access could be prioritized based on something like the CDC Social Vulnerability Index, which captures areas or neighborhoods with high vulnerability to COVID and its adverse effects. As I highlighted before, equity was a big piece of the committee's discussion. In terms of the recommendations that the committee made, the first recommendation is, of course, that the framework be adopted by various groups, but also understanding that it will need to be adapted locally based on local needs, but that the general principles and guidelines is something that the committee hopes would be adopted generally. The second important recommendation, I'm sure we'll hear more about this as well, is to really leverage and expand the use of existing systems, structures, and partnerships that we already have across all levels of government to provide, to distribute the vaccine. Of course, these systems need to be supported adequately. So it's not about creating a separate parallel system, but rather supporting the existing systems that we have. And I'm sure Caroline will talk to us more about this. A third recommendation, very important, is to ensure that the vaccine is available with no out-of-pocket cost to anyone living in the United States. And I emphasize this because regardless of immigration status, the committee felt strongly that this was very important, that anyone living here have access to the vaccine with no out-of-pocket costs. Something that I'm sure Alison may talk more about is the importance of creating and funding a COVID-19 vaccine risk communication and community engagement program. This is also very, very important. Developing and launching a vaccine promotion campaign, again, very, very important to address the understandable issues of mistrust among the population, and which is really critical. To build an evidence base for effective strategies for vaccine promotion and acceptance. And lastly, a recommendation about the global implications, and strong emphasis, a strong recommendation that the US government should support equitable allocation of the vaccine globally, not just within the United States, that the principles that we developed should be applicable globally, and a few specific recommendations like that the US join a series of international efforts that it is not currently part of that are about equitable allocation globally, and even that the US consider setting aside a proportion of its vaccine supply for global allocations and engage with the World Health Organization and all the work that it's doing to ensure equitable access globally. So if you're interested, you can look up the report, you can download it on the National Academies site, and I'll just stop there. I look forward to the discussion. Thank you.
Great, thank you, Dean Diaz-Roux. That was fascinating, and look forward to throwing a few questions your way. But let's continue on. Dr. Buttenheim.
Great, you seeing my slides there? Good, all right, so I'm gonna basically pick up where Dean Diaz-Roux left off with really the demand side of getting this vaccine out. So Anna talked about the allocation, how do we decide sort of who's in line first? Hoping Dr. Johnson will weigh in on sort of the supply side, the logistics and the organization and the rollout. I want to talk about whether people will want to get this vaccine or not, and how we might think about framing both practice and a research agenda around that. So let me just frame that by having you hold a couple of people in your head as exemplars as we talk through this. So here's Mrs. Howard, who's 58 years old. She lives in Philly. She lost both her mom and an uncle to COVID over the summer. She works at a long-term care facility and is very diligent about getting her flu shot every year. So think about how she might be responding to an invitation or an encouragement to vaccinate. Here's Kevin, younger guy, he's 26. He lives in Richmond, Virginia, not a Philly area guy. He's currently studying business. He's a Republican voter and an extreme sports enthusiast. So Kevin and Mrs. Howard, again, are just two sort of stylized examples of the 300 million or so adults in the US who will be thinking about where this vaccine fits into their life and their health decisions. What we know from a lot of good survey research that's been going on really since the spring, most recently the fantastic report from Pew Research Center, which I highly recommend, came out last month. The Pew data suggests that about 50% of adults are currently saying that they would probably or definitely not get the COVID vaccine. Let me just have that sink in. Maybe you've seen that statistic already, but half of adults are reporting that. And this is a metric that Pew has been tracking over time, again, since May. And these graphs are showing the change since May by different sociodemographic groups. And while we see differences by gender, by race, ethnicity, by age, and by education in willingness or intent to get the vaccine, what's very consistent is that those have all dropped quite substantially since May. So here we are in September, maybe only a couple of months away from a vaccine approval or authorization and rollout, and not a lot of folks are lining up to get it. When we ask people who say that they don't plan to vaccinate why, what their concerns are, probably the most common reason that bubbles to the top is some concern about side effects or more generally safety of the vaccine. So that came up for 90% of the people in that September wave of the Pew survey. But there are lots of other reasons too. Those reason lists go quite deep, as they do for other vaccine programs that we work with. But with the COVID vaccine specifically, there's also a big chunk of folks who say they just want to wait and see how well it works, which I think is also a proxy for what the safety profile looks like, how people respond. There's another big group who say, I'm not going to get it because I don't need it. And again, that's something we hear every year with flu shot. We hear with the childhood schedule, the adolescent schedule, the adult schedule, people preferring not to vaccinate for reasons of sort of don't need it. And then there are just some sort of practical and logistic concerns. I'm worried about how much it's going to cost. And those clusters of reasons can really help point us to what a vaccine promotion program might look like. But the elephant in the room, I think underlying almost all of these reasons and these changes in intentions and preferences is this idea of trust. And that's trust in almost any group you can think of. So trust in public health authorities. Unfortunately, both the CDC and the FDA have taken sort of big hits in our kind of underlying background public trust. For some communities, particularly Black communities, other minority and minoritized communities, a history of medical exploitation and unconsented experimentation have really left folks thinking, no, thank you. I would not like to be the guinea pig for you on this new vaccine. And the politicization has meant that an already rapidly accelerated process, like it's supposed to take us years to make vaccines, and suddenly this is going to be accomplished, maybe in under a year. That's already making people nervous, and the fact that the approval process has been politicized is also really eroding trust. So what happens when we have a vaccine? My husband admitted to me a couple months ago that he had this mental model that like there would be this day that they would announce that we had a vaccine, and everybody, like they did at the end of World War II, would like rush out into the street and we'd tear off our masks and start sort of hugging and kissing everybody. And I just keep reinforcing to him that, yes, there will be a day when one or more vaccines is considered, approved or emergency authorized by the FDA, but that's day one of what's going to be quite a long journey with potentially multiple vaccines and multiple layers of public health agencies involved to roll this out and encourage people to get vaccinated. We used in the National Academies report a model based on some work by Noel Brewer and Gretchen Chapman and others that the WHO has adopted called the increasing vaccination model. And it's a very useful, just high level framework for thinking about points of intervention if you're trying to increase vaccination. And we are thinking about all of these as we start thinking about different layers of vaccine programming, vaccine promotion. Some of the, what I would think of the easy ones and sort of the obvious ones happen at this sort of practical issues, green box. Anna mentioned, we think this should be free at the point of care, which includes no copays for the vaccine and no copays for the visit. We really want to think about meeting people where they are, making this absolutely as convenient and easy and no-brainer as possible. So maybe, that's at work, maybe that's at school. We don't do a lot of vaccinations at schools, but maybe we should be thinking about that. Getting pharmacies more involved in vaccination. And, let's be creative. There was an experiment a couple of years ago in New York City where you could get into an Uber and a nurse would be sitting there who would give you your flu shot if you wanted. So I think more kind of creative things so that a logistical or a procrastination or a hassle factor is not what's standing in the way of you getting that vaccine. And then there has to be clear messaging around, is the vaccine available? I don't know if anyone's experiencing this, but we've been calling around to get our older daughter vaccinated for flu shot. And, sometimes CVS has it and sometimes they don't. And sometimes they'll tell you that on the phone and sometimes you have to show up and have them tell you that's really irritating to people. And just sort of undermines not their trust in the system, but just the probability that they'll sort of close that intention to behavior gap. So again, I think of that stuff as fairly straightforward, and that we're not trying to change anyone's mind about anything or change attitudes or beliefs. We're just trying to make it super easy and free and convenient. Another set of interventions, though, are going to be around making this something that people want to get. And for some, that may mean changing their views, their attitudes, their knowledge, whatever you want to call it, from whatever discipline you work from, just to make it, to up the chances that people's intentions are high. One version, of course, that we've seen for lots of health behavior change interventions is celebrity endorsement. I have definitely heard people say, I will get it once Fauci gets it. But you might think about how someone like Oprah or Taylor Swift or other celebrities could very publicly, even vaccinate on TV to signal to people that, somebody they respect and looked up to is vaccinating. We've also been talking a lot about witnessability. So wouldn't it be great right now? I am always startled by how powerful that I voted sticker is. Like, people want that sticker. And if they go vote somewhere and they don't have the stickers, or this year with lots of people mailing the ballots, they're like, oh, but I didn't get the sticker. I'm always impressed by the sort of outsized import and impact of that sticker. Wouldn't it be great if the I vaccinated for COVID sticker was as powerful, right? And one of the reasons it's powerful, again, is it's witnessable. You're actually signaling to others that you've done this, this sort of noble thing, this pro-social thing, maybe this like cool kids club thing, right? Like, I was one of the first people to get vaccinated, and that's really neat. I put an Advantage Platinum card there as sort of a signal about, elite status. Is there a way to almost generate a little bit of what we call strategic scarcity to sort of increase demand for the vaccine, and kind of red carpet, again, sort of you're in the club if you're an early adopter. Those things can be powerful if that kind of status is important to you and if you're really looking around your social environment for guidance. We can also think, and this is very much the behavioral economics toolkit, which is my toolkit. Lots of other disciplines bring equally powerful intervention ideas to this question, but we think a lot about getting people to kind of plan ahead and make a commitment. That can be, again, like, wouldn't it be nice right now if you could call ahead to CVS and reserve a vaccine for October 15th. You could do that in August or May, like your 6-month dentist appointment, and you would know that it was sort of waiting there for you. Much more likely to go ahead and do that on October 15th if that reservation is in your phone or if you get a text reminder from them. The middle image of Ulysses tying himself to the mast so that he can hear the sirens sing, but his ship won't get caught up on the rocks, is a great example of a kind of a pre-commitment device where you make your future self more likely to do something because you put in place some restrictions or some commitment now that makes that future event more likely. And then of course, again, as you've probably been texted 10 times a day by someone asking you to make a plan to vote, we know that asking people to make a plan increases the chances that will happen. So that's another set of tools. And then finally, I want to think about how to, for folks who are really weighing the costs and benefits, not everybody does that. Not everybody makes health decisions that way. But there will be perceived costs and benefits to the vaccine. And the perceived costs may be, I'm a little nervous about this safety profile, or I'm a little nervous about how fast this vaccine was rolled out, or somebody I don't agree with politically is endorsing it. But the benefits are going to be huge, right? If they can help us get our kids back to school, or let us go back to work, or see our friends, or see our families. So thinking about kind of communication strategies or promotion strategies that make those benefits really salient, and trying to at least address or downplay the costs. One thing I'm really curious about, you saw in that early graph, I know it went by quickly, but by the race ethnic groups, it is the Black population in that sample that reported least willingness or most likelihood of not taking the vaccine. That, of course, is a group along with Hispanic Latino populations that has seen the most burden, right? The highest incidence, the highest mortality from COVID. And folks who are worried about this are starting to think about ways to work with, communicate with, engage with communities to think about vaccination as a community benefit, sort of altruistic activity. It is a service to my community, given how high the burden has been to be in the group that's been vaccinated and promote herd immunity to protect other folks. So I think there'll be some interesting, very, very community-focused interventions there as well. So I'll wrap up here. I mean, I think some key messages. This is not going to be a one-size-fits-all approach. I've been asked already by reporters and others, like, what's the message for rolling out the COVID-19 vaccine? And it is not one message by any means. This is really going to be multi-sector, multidisciplinary, multi-pronged. There's going to be print stuff. There's going to be social media stuff. There's going to be things that your clinician says to you in a visit. And it really does, just to hammer this home again, and hopefully we'll hear more of this from Dr. Johnson, it really has to leverage existing service delivery expertise and community knowledge. We're not going to invent some new program for rolling out a vaccine for COVID-19. We have really amazing programs from the federal level all the way down to the local for doing that. And I added think global, act local. I might reframe that as, think federally, vaccinate locally, just to emphasize that there will be a lot of sort of micro programs that get the right message based on someone's specific barriers to them at the right moment. And I listed below just some of the disciplines and sectors that I think are going to need to be involved here. So that's where we are. I mean, if you think about a program that will meet both Mrs. Howard's needs and Kevin's needs in promoting the vaccine, and something that will hopefully get as many of us as possible over that hurdle so that we really can run in the streets and declare this part of the pandemic over. And I'll stop there. Thank you.
Outstanding. Thank you so much. Moving on to Dr. Johnson.
Hi, I don't have any slides, so I'm just going to talk and tell you what the local health department's role in this is. So the CDC and the local health departments are not at all involved in the approval process for the vaccines. I mean, we sort of trust that the drug manufacturers and the FDA and the approval process will move along, and that someone will give to us a safe and effective vaccine. So we don't spend a lot of time talking about safety and efficacy, although it's very, very important. That's someone else's job. Our job is to get the vaccine distributed and into the arms of people who need it. So this is not going to be like measles, mumps, and rubella vaccine. This is not something where a private physician can order this product from a drug manufacturer. Hospitals can't order it. This vaccine is completely, I'll say, under the control of the federal government right now. And I believe that the vaccine will come out through two big agencies, one of which is the CDC, and one of which is probably going to be DOD or Defense Department or some federal group that's going to represent the military and the State Department. We don't have anything to do with that federal side. The CDC is going to I'll say control release of vaccine to the population, apart from the ones that are being handled by the DoD. They do this already. You probably don't know too much about the Vaccines for Children program, but childhood vaccines are for children who are covered by Medicaid is already a federalized program, which means that the CDC sort of controls the release of vaccines to local health departments and providers. And the local health department oversees this process already. 70% of the children in Philadelphia are covered by a Medicaid insurance, which means that basically the local health department has some responsibility for making sure those vaccines get to those children. So what we're being asked to do for COVID-19 vaccine isn't really anything different than what we always do. It's just a little more of it than we normally do. The CDC funds, I believe it's 67 immunization grantees, or maybe it's 62, I've forgotten. It's all 50 states. It's a handful of cities and territories who are direct grantees of the CDC to run immunization programs. Philadelphia is lucky enough to be one of them. So we operate independently of Pennsylvania. We will get our own allocation of vaccine. We will establish our own processes for distributing it and defining who gets it and running communication strategies. Now, we don't operate in a vacuum, so we do try to be consistent with what's going to happen in New Jersey, Delaware, and Pennsylvania, but we control our own allocation, which will be population-based or population size basis. At least initially, we think that's what's going to happen. Philadelphia, I believe, has 0.5% of the nation's population, so whenever they tell you they're releasing this amount of vaccine, multiply it by 0.05%, you'll figure out how much is coming to Philadelphia. Because they generally do not take into account whether more seniors in Philly or fewer seniors. They will not do that. It'll likely be a very straight population base. And so that vaccine will be allocated to the Philadelphia Health Department to get it distributed. So what our role is right now is we have to identify providers who are going to give out the vaccine, be able and willing to give out the vaccine, and who are going to have access to the priority populations. We have to identify the priority populations that we're going to serve first, which is likely going to be very influenced by how much vaccine we get. So it's hard to say exactly, but we have to identify those priority populations. We have to figure out what the best venue is to give the vaccine. So are we going to have walk-in clinics? Are we going to do this through provider offices? Are we going to have people lining up in the street 6 feet apart? You know, so we have to do all of those plans. And we have to make sure that we report all of this to the CDC in an ongoing fashion. So this program is going to operate in what I call a dose replacement fashion. So if they send us 5,000 doses on the first day, we won't get another dose until we show that we've used a dose. So it's not a one-way flow where here's allotment and then you can order some more. We have to show that we're using it. We're going to have to show that we're using it in the right populations. And so the reporting of this is very, very important to assure that we have a continued stream of vaccine. We have to assure that there is monitoring going on, particularly because of the concerns about adverse events. Not that we think the vaccine is going to have any more or less, more or fewer adverse events than any other vaccine, but clearly, as Alison just mentioned, there's a huge concern about Operation Warp Speed and kind of circumventing safety. So I think the more data we can show that we gave X number of doses and we had no adverse events is going to be very important. So the monitoring of the safety and the efficacy profile will be important. And we're going to have to develop our own communication strategy. This one's a little new for us. I told you, we have a whole lot of experience with all the other parts of distribution. But I will tell you that in past years, we pretty much could count on the CDC to generate a really nice marketing campaign for whatever vaccine that they were working on. I've been very involved in HPV vaccine for adolescents, and the CDC's done a wonderful job with a lot of those campaigns. And I would say locally, mostly, we just either push out the same message or we tweak it and kind of target our audience. But I think in all fairness, from everything I've heard from all the experts and from talking to people, is that messaging from the federal government isn't being looked at very favorably these days. And that messaging from the CDC may not do what it usually does. And we are being advised that the more that we create a local message and have local messengers give it, the better off we are. So we're really going to go down the path of creating our own communication strategy. So the whole process I described to you, we created a vaccine advisory committee across the city with experts from all different fields and representing all of the most vulnerable populations to kind of walk us through these things and make sure that we are in alignment with what they all see we should be doing. And we have some ethicists who are going to have input into that to make sure that we really are making our decisions correctly. And a few other things about the logistics. Last Friday, our first draft of the plan was due to the CDC to talk about how we're going to be doing all of these things. And I think we have a very good plan on paper. Operationalizing everything is always a lot harder than it actually appears to be on paper. But we are moving ahead with some strategies that will probably reach out to the earliest tier populations, which are going to be healthcare workers, some vulnerable populations, and probably some of the critical workforce that have been identified as special needs in this city. We also are very aware of issues of inequity and assuring equity. And I think, Anna mentioned one of them that was brought to us, and I think it's an excellent idea, is some of the professions in this city have shown the highest disease rates independent of race, as well as being occupied by people from minority populations. And I'll say, for example, grocery clerks. I don't know why we have so much data about grocery clerks, but we're collecting data on all the cases. And they have an extremely high attack rate. And they also are a population that has had inequities in the past, because many of them come from African-American or Hispanic communities. So, we have decided, based on the Vaccine Advisory Committee, that that's a population we probably want to tackle in our earliest phase. It's one way to help achieve health equity, as well as protect a very specific, important population. So, we are taking our job to make sure that health equity is addressed here. We take it very seriously. Let's see. Well, I'm not sure I really want to say anything else about this. Again, the distribution is what our role is. By the time this plan rolls out, I think in the earliest stages, we're expecting potentially to see some vaccine in December. We're acting as if we're going to see it in December. Whether we do or not, I can't predict. But We think that the earliest vaccine is going to get into occupational health offices of the hospitals. We are engaging with pharmacies to address the long-term care. The CDC is probably going to be contracting directly with pharmacies to go into some of the long-term care facilities and immunize staff and patients there. And I believe that we will be doing most of the high-risk critical occupations, such as the food workers and grocery clerks, in a community clinic type scheduling process. So we will stand up some very specific clinics to deal with that population. And I think I've already sort of alluded to the fact that, you know, not only do we have to get people vaccinated, we have to make sure that we're meeting all of the safety precautions while people are in line to get vaccinated. So we now have to convert most of our vaccination models to a schedule model. Most of the time when we do vaccination, we have people just queue up and they move through very, very quickly. But we can't do that because we can't have more than a certain number of people in a limited amount of space. So we're transitioning most of our mass vaccination models into a pre-scheduled type of event. So that's a switch for us, but it's something I think that we're prepared to do. So I think I'm just going to stop there and turn it back over to Michael. You're on mute. You're on mute.
Thank you, Dr. Johnson, and thank you for pointing out my Zoom faux pas. So we've got about 12, 13 minutes left, and I want to give a chance for the audience to ask some questions. So please, we've got about 4 questions in the chat box. Oh, we got some more coming in, so I'm just going to go right to some of these questions. We have a question about health events occurring during the mass administration of the vaccine. People will continue to get sick and correlate that perhaps with the vaccine, even if it has nothing to do with it. In some cases, there may actually be events. How do we communicate that this is normal and effective to the public to prevent any hysteria or aversion to the vaccine? Alison, I guess I would turn to you with that question.
I was hoping you weren't going to do that. This is really hard, right? So now, you know, if you take your kid to be vaccinated, or if you get a vaccine, you get that vaccine information sheet from the CDC, the VIS. And of course, if you start vaccinating tens of thousands and hundreds of thousands and millions of people, as the questioner said, people are going to have just bad events unrelated to the vaccine in the hours or days following that vaccine. People will have heart attacks, people will have strokes. And so I think part of the risk communication and part of the sort of logistics side of the rollout is going to be communicating to people that we are keeping track of those things. There is a post-market surveillance. We do the paperwork and the epidemiology to make sure that we can get a signal if some of those events start happening at higher rates than we would expect, and that we need to sort of make sure that that's not vaccine related. That is something that the public just should and needs to have trust in, that we do that kind of surveillance. But we hear about these things as individual stories that are very persuasive. Oh, my daughter fainted. Oh, my dad had a stroke the day after he got the vaccine. And those stories are very powerful. It's harder to communicate the 1 in a million, 1 in 100,000 type events that we do a very careful job of tracking.
Got it. Thank you, Alison. I'm going to turn to another question. Anna, this one's for you, relating to the National Academies Committee, about priority levels for vaccine for those who participated in clinical trials and who received a placebo. Do you know if they will be given any consideration?
Yes, the committee discussed that. And I think, you know, in the grand scheme of things, this is not a super large group. But the assumption was that a condition of their participation in the trial would be that they would receive the vaccine when it was approved. So this is why they're not highlighted as a particular population group, but the assumption is that they would be high on the priority list. Yes. Okay,
great. Anna, I want to just follow that up with a quick question. In your in one of your slides, you were talking about one of the priority groups being those who are at significantly higher risk. And I'm wondering how big that group might be given, some of the underlying comorbidities that are associated with COVID, from diabetes, which we see rates very high across the country, to overweight and obesity. So how do the committee think through some of those challenges?
Yeah, that's a complicated issue. And I'm not, I think there are a number of issues that still have to be refined. If a framework like this is implemented, each health department would have to take it and, figure out how they adapt it to their local situation and their local needs. But in terms of the numbers, so roughly the committee assumed that phase 1 would be about 15% of the US population. And so that gives you a sense when we talk about people at high risk, significantly high risk, it's pretty high risk, right? Because, if we take everyone who has a BMI over 30, that's a lot of people. So the phase 2 is about another 30%. Phase 3, I think, is about 40%. So there's some numbers in the report that give some guidelines, but a lot of the operational details of this will have to be worked out locally, as Caroline was saying. It can't be done in a standardized way. But
so, Dr. Johnson, I'm going to turn to you with a question. You had mentioned that you are preparing for vaccines to come to the city at the end of the calendar year. Is there a sense of, if that happens, how quickly the citizens of Philadelphia could be vaccinated across the board?
So, I think the early limiting step is the amount of vaccine we get. I believe that we're going to have enough providers to administer vaccine to the so-called phase 1. This is the healthcare workers and the vulnerable populations. We will be able to get them immunized. I think our estimates are 4 to 8 weeks, which is probably in line with the amount of time it's going to get for us before we get new vaccine. So I think the early vaccination strategies are going to be done timely. Where I see the slowdown occurring is in the so-called phase 3, the CDC's phase 3, which is when the vaccine is sort of operationalized to be given to the entire population, with the thinking that it is going to be introduced into routine primary care. So I think that's where they sort of see that everybody gets this at the next doctor's visit. That I think is a bigger chore and is going to take more time. We kind of learned this with the H1N1. We could push vaccine out quickly very early on when there was enthusiasm by providers and patients to receive it. But then you get about halfway through the population and both of those things begin to wane. So like I said, I think we'll get through phase 1 in about 4 to 8 weeks. Phase 2, which is sort of the next part of that to finish other people out who have some kind of risk indication, is probably going to be another 2 to 3 months. And then I think the remaining 6 months will be to try to get the rest of the population who may not even want vaccine. So that's going to be a longer and harder uphill push, I think.
So
can I ask a follow-up, Mike?
Go ahead. Yeah.
I'm just curious, this is going to sound like a really wonky technical question, but does it make a difference to your plans, Dr. Johnson, if there's a -80 cold chain vaccine versus something more around just regular cold chain sort of freezing? Or are you able to
it makes
handle
a
it no matter
huge
what?
difference.
Yeah.
Makes a huge difference, because if it's a cold chain vaccine, apart from the traditional cold chain, that's what they're calling the ultra cold. It means that the shipping has to go directly to the provider. It can't sort of come to us to redistribute, which is a lot of times how we handle this. It also means that the packaging is going to come with very large quantities. So we've already heard this about the Pfizer vaccine. None of this is secret info I'm leaking to you. The Pfizer vaccine, which may be one of the first ones out of the chute, is going to come in a package with 1,000 doses. So, and you have to use all 1,000 at least within 10 days, if not sooner, if you reconstitute it. So we're not going to be able to let them ship 1,000 doses to a small provider's offices. This ultra cold chain really means now we really have to centralize this into larger providers who can see a lot of people and not waste vaccine. So the requirements of vaccine handling absolutely are going to influence which way we go. But it's sort of paralyzing for us because we can't plan for one over the other right now.
Right.
To know what we're going to get. But that's why it's it's a little bit fuzzy about how this will all work because of problems like that ultra cold chain.
Thanks for letting me jump in with that.
We've got just a couple more. Yeah, no problem, Alison. We have just a couple more minutes, and I wanted to follow up that question with a question about children. The current trials are not with children. Children face a much lower risk of morbidity and mortality from COVID, but at some point we are likely going to want to vaccinate kids as well. Any thoughts on a timeline for that? Is that sort of the next phase, and we'll see that later in 21?
Mm-hmm. So the earliest vaccine is undoubtedly going to come out under what's called an EUA, an emergency use authorization from the FDA. Children will not be covered by the EUA. So the first vaccine that comes out, there will be no indication for children. We're not even sure if there's going to be an indication for seniors, depending on what the clinical trial enrollments look like. But we know that there'll be no indication for children. And there certainly won't be until this has a full FDA approval and studies are done. So I'm gonna estimate that that's 6 months away. I don't think anybody's even doing trials with children, certainly not in the United States. I don't know for sure on all the international trials, but I would say we're 6 months away from seeing pediatric vaccine, at least.
Great. So I want to throw out one final question as we wrap things up, which, we're given this Operation Warp Speed involves many vaccines with the potential of a good number of vaccines coming to market. How do we manage that from a public health perspective in terms of people making choices about vaccines? Will they have choices? What happens if one vaccine in sort of the aftermarket follow-up doesn't look great? Will people be able to get a different vaccine? Just a few questions for the group to close things out.
Well, I'll start off and then let other people finish this. I can tell you a couple things. First, we do know that if you start the vaccine series, by the way, most of the vaccines are going to require 2 doses, 3 or 4 weeks apart. If you start with vaccine A, you have to get your second dose with vaccine A. You cannot use them interchangeably. It's another reason why this whole reporting of administration and documenting it is important, so we know how to do reminder recalls for those second doses to make sure they get the right vaccine. We know nothing about the issue of do you get revaccinated with the better vaccine if you learn something down the line? I can't comment to that, but I will say providers are very used to multiple different formulations of flu vaccine. And matter of fact, I think they're so used to it, they really think about them interchangeably, that not quite interchangeably, but it doesn't seem to perplex the providers that much. I think this may be more a public perception issue. And admittedly, I have the same questions. If I were a healthcare worker seeing patients and I knew there were a better vaccine out there, would I want the second dose? A second vaccination? I can't answer that question for you, but it does come up.
Got it. Dr. Diaz-Roux or Dr. Buttenheim, do you want to jump in on that?
Yeah, I think two things echoing what Dr. Johnson said. I don't think we want the public, the patients engaged in making the choice about vaccine A or vaccine B. That can be a provider choice and we can take that off their plate. I do think depending on the news that's coming through and people trying to read the tea leaves, if there's a thought that the first approved vaccine is lower effectiveness, I think people will sit tight and wait. So we may have a harder time getting up to the coverage we want if there's a lag and people expect that vaccine number 2 is going to be more effective.
I'll just say quickly, I mean, I think what will be very important is that we sort of as a public health community are vigilant and making sure that we, that we approve a vaccine following the process that we think needs to be followed, and that we communicate in a transparent way about that with the public, in a clear and transparent way about what approval means, what efficacy means. We're just going to have to figure out ways to really communicate about this in a way that's completely honest and transparent, because the vaccine is not going to be perfect. It's not going to cover every, it's not going to be 100% effective. It's not going to be, there will be some uncertainty, and we just have to communicate the risks and the benefits in a clear way. There's nothing else we can do, I think.
Yeah. So I want to thank the three of you for generously sharing your afternoon with us. I want to I think we were up to 135 viewers at one point. There was a question in the chat box about this being recorded, which it was, and it will be archived on the Dornsife School of Public Health at Drexel's website. So please, if you want to share this, check into that and share it. The next webinar in our series will be racial disparities in COVID-19. On Thursday, November 5th at 4 p.m. We have an amazing panel hosted by one of my colleagues, Dr. Amy Carroll Scott, who's an associate professor in my department, and also joining her are Ana Martinez Donate in the Department of Community Health and Prevention, and Dr. Sherelle Barber in the Department of Epidemiology and Biostats. So please tune in on November 5th. Keep reading the news and checking in and staying engaged on this, and hopefully there will be good news to come soon. So thanks to all of you. Thanks to the audience. Have a great afternoon.